This morning, we're going to kind of switch gears here and not talk about pharmacology and drugs, but to review just some chemotherapy safety tips and points, chemotherapy counsel, and then a little bit about drug shortages, which I'm dealing with this morning. So just for everyone to have kind of a level set review of kind of early medical school, I think. A medication error is any error occurring in the medication use process. And that medication use process is everything from patient information and drug information up through environmental factors, patient education, and quality processes. So it can happen anywhere in those processes. So how do medication errors happen? You all remember the Swiss cheese effect. There are some holes due to active failures and other holes due to latent conditions. We do have successive layers of defense, such as CPOE for chemotherapy. We have standard core treatment plans. We'll talk a little bit more about that later. We have chemotherapy competency for everyone that deals with chemo at UW Health, and independent double checks of chemo. But despite that, we do know that errors can get through all of these layers of defense and unfortunately reach the patient. There is no perfectly safe system, unfortunately. So back in 1997, Klassen and group reported adverse drug events, including medication errors, increased the length of stay by an average of 1.74 days and have an average cost in 1997 of $2,262. We know that that's at least that today as far as length of stay, and of course the average cost has gone way up. And then various authors have reported that 42 to 67% of the serious adverse drug events are preventable. The FDA every year receives more than 100,000 reports of medication errors, which seems, and these are the serious errors that they get reports of. And more than 7 million patients in the US are impacted by medication errors every year. And about 10% of all hospital patients will be subject to a medication error. Like specifically, chemotherapy errors can range from just incomplete orders to life-threatening errors. And studies show that chemotherapy errors occur at a rate of about 2%. They affect about 1 to 3% of both adult and pediatric oncology patients. They occur at all stages of the medication use process. Oral chemotherapy use is a particular area of growing risk. And this is likely due to the fact that access to patient-specific information by outside pharmacies is still not great. So despite Care Everywhere and some other initiatives, it has been more difficult. And then the amount of medication taken per dose should be put on the prescription, not as total daily dose to be divided. Oral chemotherapy is kind of a unique issue. So why do we focus on chemotherapy safety? Obviously, medication safety concerns are not unique to any drug, but oncology does have some specific things that make it a little bit more dangerous. Among them, the antineoplastic agents have the lowest therapeutic index than for any other class of medications. Even subtherapeutic doses can cause harm to the patient, right? Not just overdoses, but if we give a patient too little, it can certainly affect outcome. And in chemotherapy, the dosing interval and the route of administration vary significantly as a function of the specific tumor type and the stage of the disease and what other drugs you're using it for. Some examples I normally provide is that a normal dose of methotrexate can range from 10 milligrams for intrathecal chemo up to 20,000 milligrams for osteosarcoma. So it's a little hard to know, what is a normal dose, and some of the things that we use to prevent errors in traditional medicine. And total doses and infusion durations of 5-FU for colorectal cancer vary widely across regimens, even for the same stage of disease. And again, another example is cytarabine dosing, which varies widely depending on indication, route of administration, and of course, length of infusion. This is a list of the ISMP best practices for safety for 2021. So Institute for Safe Medication Practices is what ISMP stands for. And if you notice, the two top ones are oncology related. So we continue to see vincristine and other vinca alkaloids inadvertently administered by the intrathecal route, and then accidental daily dosing of oral methotrexate when it's intended for weekly administration. So, for rheumatoid arthritis and other things, oral methotrexate is administered weekly, but we do use daily dosing in the oncology world, and that has caused problems, including death. You can see some other top best practices for safety there. We changed our vinca alkaloids to bags, given in small IV bags rather than IV push, because it seems like the syringes were the ones that were getting confused with giving intrathecally. And that actually did happen here at UW Health, probably about 16 years ago now. Just to share some selected chemotherapy medication errors and outcomes that we've seen, we continue to see bortezomib given intrathecally, inadvertently, resulting in multiple deaths. We're using bortezomib in research studies anyway. In leukemias where we do a lot of intrathecal chemo. Carboplatin overdoses continue to happen there. Carboplatin and cisplatin, when you confuse the proper dose ranges, cisplatin was administered at a dose intensity appropriate for carboplatin, consistently fatal outcome. There's numerous examples of that. Docetaxel and conventional paclitaxel, the dosing was confused for that. A patient died 5 days later, although it was unclear if the death was due to error or underlying disease. The dosing for doxorubicin and liposomal doxorubicin continues to be confused. Fluorouracil injection, a dose intended to be given over 4 days, was given over 4 hours, causing patient death. Lomustine continues to be a problem. It's an old oral chemotherapy agent. But serious errors have occurred when this oral agent was given daily versus every 6 weeks, as it's intended to be given, causing patient harm, prolonged hospitalization, and death. And then, of course, the methotrexate that we talked about on the previous slide, where multiple cases of accidental daily administration of oral methotrexate when weekly was intended, at least 25 fatalities and an equal number of incidents of serious patient harm. And then vincristine and vinblastine doses also are confused and cause serious harm, including death. So this is the Dana-Farber story, and I still tell this story. I was a pretty young oncology pharmacist back in 1994. And Betsy Lehman and Maureen Bateman were prescribed and received 4 times the intended dose of cyclophosphamide. So this is back when we gave cyclophosphamide as conditioning therapy for the auto stem cell transplants we used to do for breast cancer, which of course didn't work out well anyway, but this was certainly a problem. And instead of prescribing the daily dose to be given on each of the 4 days of the cycle, the combined 4-day dose was given on each day. 25 different medical staff were involved, and not one noticed the problem until weeks later. And this included attendings, fellows, nurses, and pharmacists. Betsy Lehman died as a result of the error, and it was actually due to heart failure, not they were able to support her through the cytopenias. And Maureen Bateman suffered permanent heart damage and subsequently died of her original cancer several months later. So this really started the chemotherapy safety movement. I was at a cancer center in New York. We started looking at what we could do to prevent this. And a lot of our chemotherapy safety things that we do now are a result of these errors. And Betsy Lehman's family actually set up a medication safety institute at Dana-Farber, which is still active today. This is another horrible story, the Rainbow Baby story. And this one, the pharmacist actually went to jail over this, although it was a human error. basically, the child was to get etoposide in normal saline. They were out of normal saline. It was a weekend. And they compounded their own saline with high dose saline, and the child died. It was a horrible error, but also it does make you think about, you know, how we treat errors that are simply a result of human error. It's interesting. I've heard the father of this child speak, and if you ever have a chance to hear him, it's really pretty good. He ended up visiting the pharmacist in jail. They actually speak together a lot now, but it did also change how we think of chemotherapy safety. High-dose methotrexate is kind of near and dear to my heart, as well as Mike Fallon, who's done an enormous amount of work on this over his years at UW. We've had 4 serious medication errors since 2010 here at UW, including 2 ICU stays, 1 acute kidney injury, and possibly 1 death due to this. We've made a lot of different changes in the way we give high-dose methotrexate, in our monitoring, and in our treatment plans to shore up our defenses. We also have a high-dose methotrexate clinical practice guideline that we've used to try to make this rather dangerous drug safer, and I've linked it here in the slides. So what are some potential causes of chemotherapy-related medication errors? So certainly miscommunicated verbal orders, which is why here at UW and at most places, verbal orders for chemotherapy are prohibited other than to stop chemotherapy. The total course or cycle dose given daily, a lack of pertinent patient health information, such as current lab data, patient demographics, use of incorrect patient information or lab data. Here at UW, we've had errors due to, instead of inches, putting in centimeters or vice versa, which of course gives you the wrong body surface area. Excessive interruptions during order processing or dose preparation. We try to emphasize to our pharmacists to get in a quieter area and to focus, and the same with our nurses that do these checks. Uses of abbreviations, slang, and common drug names when discussing ordering and charting. I think we're very guilty of this in oncology. We use a lot of abbreviations and common drug names, which to us is very knowable, but you know, when you think of new personnel starting, it may not be the best way to communicate. And then lack of a copy of the physician order or treatment plan or protocol, and or an article that details the protocol, so the original evidence, which we have put in all of our treatment plans. And then failure to round doses to the nearest whole integer. We continue to work on this. It's a little bit hard with the electronic ordering system, but obviously a vincristine dose of 1.456 cannot be measured. So we need to make it something that's measurable. So one area of, as we talked about with the vincristine, inadvertent intrathecal chemotherapy. We have addressed intrathecal chemotherapy safety here at UW Health. We do have a policy, it's linked there at the bottom. We do state that only methotrexate, cytarabine, and cytarabine liposomal can be given intrathecally at UW Health. And then there's some other items that can be used as flushes or to dilute the drugs. Inadvertent intrathecal administration of drugs such as vincristine and bortezomib is still reported in the literature. I worked on this with some pharmacies learners back probably 12 years ago now here at UW, and we now routinely prepare vinca alkaloids in 25 ml IV piggyback bags versus the traditional way of preparing it, which was in a syringe, to prevent recurrence of this type of error. The UW Health error, I guess, was in 1999, so a little bit further than what I thought, but we didn't change to IV piggyback vincristine until 2010, which is kind of interesting. So for 11 years, we did have this issue. it presents a struggle for balance between prevention of fatal errors versus a risk of non-fatal, but certainly severe adverse drug events, such as extravasations. So an IV push might be a little bit easier to prevent that. But certainly the fatal errors from inadvertent intrathecal administration is certainly more important to consider. And then here at UW, as it should be anywhere, any intrathecal administration of a drug must be preceded by a timeout, such as like a surgery timeout, right? Where we make sure we have the right patient, the right drug. Here at UW, what happened is, of course, vinca alkaloids are given for treatment of leukemia, right? And they're often given at the same time that we give intrathecal chemo, so vinca and vincristine and IT methotrexate or IT cytarabine. The patient was due to get their kind of last treatment. It was an ALL adult patient. And we, the pharmacist thought the doctor wanted the IT chemo. They came to the pharmacy. They unfortunately gave them the vinca alkaloid and the IT chemo. The physician took both of those to the bedside, started to administer the vinca alkaloid intrathecally. Fortunately, stopped, only a little bit got in. However, this patient did have, was a quadriplegic. Due to this, he did survive, one of the few patients that have survived this error. And the physician that, one of the physicians that was there when all of this happened and they were trying to figure out what to do, was still here when I got here about 13 years ago and could still talk about this error, remembered it like it was yesterday. So anytime we present this policy to the UW Policy Committee, the attorneys go nuts if we try to change anything, because it really is a horrible error to have happened, and people can still remember what type of suffering it caused for that patient. So years ago, almost 13 years ago now, we changed from paper orders for chemotherapy to electronic prescribing. But there are still sources of errors in electronic prescribing, even though it is much safer than it was on paper. So any kind of incorrect data entry, such as incorrect patient weight, an error in electronic build, which can happen despite all of our kind of fail-safe if all the Swiss cheese holes line up. System design, such as poor data organization or data omissions, workflows outside of the electronic build, trying to kind of get things done, maybe what someone might decide was more efficient. Confusing chemotherapy treatment plan option presentation. If you all have tried to look up a chemotherapy treatment plan in Beacon, you know that it's very difficult sometimes to figure out which treatment plan you really want. We are working on that, but it may result in the choice of incorrect treatment plan if people aren't paying attention. We've also found some prescriber issues. New practitioners or trainees may not learn how to write chemotherapy orders due to an overdependence on technology. So kind of like, well, it's in the computer, so it must be right. So how we train you, I guess, and quality assurance has become important. There is a tendency to view signing a Beacon treatment plan as a task to complete rather than as a tool to safely prescribe chemotherapy. And then there have been copy and paste issues within treatment plans. A couple of years after we started the Beacon treatment plan, we gave the fellows, two of the attendings and myself gave the fellows kind of a quiz just on, what are the doses of kind of some common drugs. I think we used rituximab, docetaxel for prostate cancer, a couple others. And the fellows were not able to give the doses because it's in the computer, right? And they don't have to know it. They don't have to write the orders. They don't have to remember it. And so how we teach this has become more difficult to ensure that you all know how to prescribe chemotherapy safely. We've had copy and paste issues where a bevacizumab dose that was supposed to be given every 3 weeks was put in to a weekly plan. So the patient actually got bevacizumab, it wasn't caught. So copying and pasting, we need to be extremely careful. So now we're going to transition over to the medication event reporting, or the HERO system, which is a new system for reporting adverse drug events here at UW Health. The goal, of course, of any event reporting system is to report med errors, adverse drug reactions, near misses, and risky situations in order to improve patient care, promote education, and comply, of course, with accreditation standards. It is a way to gather information and then to develop solutions to events that have occurred. So making systematic changes. Also a transparent means of discussing safety solutions for our institution and a forum for identifying opportunities. What it really isn't is punitive. So we support just culture here, which is open idea sharing and discussion, not assigning blame. We understand that humans make errors, and we're not going to be able to get away from that. It's also a venue. It is not a venue to discuss topics outside of safety related issues. So we do try to keep it, based on the issue at hand. So what is reported in a medication event? You guys probably know this, right? So events that occur: a late drug delivery, a scheduled medication was not administered, the 5 rights were not followed, near misses, so catching an error before it occurs. And a lot of times these near misses are very valuable in preventing future errors. Risky situations, reportable ADRs, confirmed or suspected, that result in either a discontinuation of a drug, a change in drug therapy, including antidotes, and also ones that result in hospital admission or prolongation of a hospital stay. Some ADRs, of course, are reported to the FDA. And adverse drug reactions include preventable, predictable, non-preventable, and unpredictable reactions. For example, rituximab infusion reactions are reported fairly frequently. So each event is evaluated by quality, by risk management, by a physician, pharmacy, and nursing at a minimum. So we bring in respiratory therapy, we bring in lab as needed for these medication events. We really look at finding the reason that the event happened, and then changing the systems that allowed it to happen. And then data is collected also and presented. So we do monitor like chemo errors for the year, for example. This is just for your own reference, and it's a guide to how to enter a new event into HERO. It's kind of funny, a pharmacy resident that was with me submitted the winning name for this new system, and his name is Haroland. So he thought it was pretty cool that he came up with some sort of an acronym that included his name in it. So Chemotherapy Review Council, I'm sure all of you have heard of this. We have an adult one, and then the pediatric one uses the tumor board, pediatric tumor board, for the same type of functions. So basically it provides a mechanism for evidence-based peer review and approval of chemotherapy regimens for the treatment of adult and pediatric malignancy. It promotes the use of chemotherapy regimens with documented safety and efficacy, and it enhances uniformity and safety of care through that use of standardized regimens with defined treatment plans. We know the more that we standardize things, the less chance there is for error. It is a standing committee of the UW Health Pharmacy and Therapeutics Committee, which reports up to the medical board. Through this committee, we have formulary requests, so any new chemotherapy drugs come through us because we have the experts that know these drugs. We consider both core and patient-specific regimens, and then the development, review, and implementation of any guidelines, policies, procedures, order sets, delegation protocols, and medication use evaluations related to the treatment of cancer here at UW Health goes through these committees. Dusty Deming and Natalie Callender are the current co-chairpersons. Dusty kind of focuses on solid tumors and Natalie on hematology related issues. So it's worked pretty well. We used to have just one chairperson, but I do believe these two chairpersons has been a good improvement. The pediatric tumor board is really the group of pediatric hematologists, oncologists, and other physicians. In the big chemo council, Jason Bergsbakken, our clinical coordinator, is the secretary. So he does all the agendas. He works with Dusty and Natalie to get things on the agenda, sends out any patient-specific regimens. We also have physician representatives of various DOTs. We have nurse clinicians. We also have an APP delegate now. I think we're looking to put 2 on eventually, but we do have 1 on at the moment. We have clinical oncology pharmacists, and then we always have a HEMONC fellow, and that rotates through on a quarterly basis. So you'll all get to experience this. All chemotherapy given at UW Health must be approved as one of the following. So it's either a study or it's a core, which is a standard of care regimen. So we're saying that for late stage triple negative breast cancer, we're going to use this group of regimens, and those are our core standard of care regimens. The same thing goes for pediatric regimens. And then we also allow patient-specific regimens. These also have to be voted on or approved by the chemotherapy council. They're sent out via email. And this is usually for one of several reasons. Either it's a molecular tumor board recommendation, and for those we just vote on safety. It's a rare disease. There's some patient-specific factors that need a regimen outside of the core regimen. It's a newly approved therapy, and we haven't taken it through chemo council yet. That happens to be quite a few of them. Or there's a level of evidence for the regimen that's really not sufficient for a core regimen. We do require a higher level of evidence for core regimens, as you might expect. So resources can be found here. This is the UConnect page. If you just type in Cancer Center, you can find all of these things. You can find information about oral chemotherapy, our blinatumomab workflow, which we have not discussed today, of course, chemo council, and then high-dose methotrexate can all be accessed from this page. When you go into the chemotherapy council or chemo council area subpage, you can find the core regimen submission form, the patient-specific submission form, as well as the molecular tumor board recommendation submission form, which is of course much shorter. This is the core regimen submission form that we ask the physicians and the APPs also work on these sometimes to submit to us. As you can see, it's not a lot. We do ask for a place in therapy and an estimated number of treated patients per year, so we can do the kind of financial review, what effect it'll have on the institution. We also ask which references you'd like us to consider. And if you have information to facilitate the beacon build, this part is filled out. The rest of it is done through drug policy and Jason, who work together to come up with a kind of longer submission for the chemotherapy council for these core regimens. They're taken to monthly meetings and voted on there. The submission, once drug policy and Jason work on it, do go back to the DOT so that we can make any edits or changes that they want us to make for those. This is the patient-specific submission form. The difference here is that we're asking you for a justification and a reference as to why this regimen should be used for this particular patient. Chemotherapy drug shortages, unfortunately, something that continues to happen here. Watching time. So the FDA did identify 3 root causes for drug shortages. I'm often asked, why did this shortage happen? So we know that there's a lack of incentives for manufacturers to produce less profitable drugs. You can read there, like all of our chemotherapy, traditional chemotherapy agents that are off patent now. So they become less profitable. There's really not a lot of incentive for manufacturers to fix things or to continue to produce them. The market really doesn't recognize or reward manufacturers for mature quality systems that focus on continuous improvement and early detection of supply chain issues, which would prevent some of these errors from happening. And then logistical and regulatory challenges make it difficult for the market to recover from disruption. So this is pretty interesting. This is the number of new shortages per year. And you can see back in 2011, we really had a lot of new shortages, where now it's been pretty steady since about 2013. There's around between 40 and 50, I guess, per year, new drug shortages. These aren't kind of the continuing ones. So these are some recent examples of chemotherapy drug shortages. The two that we're still dealing with right now are dacarbazine, which is a relatively new one, and then Abraxane, or paclitaxel protein bound, came up this weekend, and we're really going to, this one looks pretty problematic. But as you can see, all of these drugs are used in curative intent for several different types of cancer disease states. So it is problematic, and we knew that we needed a systematic way to deal with chemotherapy drug shortages here at UW Health. We didn't want to like totally run out of a drug and then not know what to do. This is an example of the dacarbazine shortage that I'm working with right now. So these are the products that are affected. The reason for the shortage does not seem very satisfying to me. There's manufacturing delays, and one company doesn't even provide a reason for the shortage. So estimated resupply dates, maybe late September for the 100 milligram vials and early October for the 200 milligram vials. Teva doesn't even estimate a release date. So if we only have one of two companies making it, there's going to be some problems with supply. So because of these chemotherapy drug shortages for drugs that are used to cure disease, we came up developed a drug shortage allocation plan. So the plan development, so we used the Chemotherapy Review Council, and this was selected to develop a plan to manage chemotherapy shortages. For this particular purpose, when it affects pediatric cancer care, we do pull in pediatric physicians, hemonc physicians, to sit on the kind of specific chemotherapy shortage panel. We established 3 levels of shortage. One is just the warning of an anticipated drug shortage, which doesn't seem to happen a lot. Usually we just all of a sudden it's on shortage. Shortage is unable to order a supply, less than 3 to 4 weeks supply available at the hospital. And that is actually both the dacarbazine and the paclitaxel protein bound at the moment. A critical chemotherapy shortage is where there's less than an estimated 1 to 2 weeks supply of the drug, and that's based on historical usage. When this happens, we convene the Chemotherapy Review Council, including other people that we need for the particular drug. And they'll review, and then we rank cases using the guidelines that's on the next slide. No chemotherapy drug in critical shortage will be dispensed without the approval of a quorum of the council. So we did have to do this once for cytarabine, where we had to decide which of our current patients were going to get the drug. Fortunately, like right as we were implementing it, we got a new supply of the drug and went back up to the shortage state, but it was a very painful process. So how we prioritize patients, this is used especially during the critical chemotherapy drug shortage stages, but we also start thinking about it during just the shortage phase. The first priority is the curability of the disease. So we want to use, of course, I guess a good example for the dacarbazine is we had a number of patient-specific requests for single-agent dacarbazine for adult sarcoma patients who are not curable, and they're obviously trying to extend the life and normally would not be a problem. But obviously, since we used dacarbazine to cure Hodgkin's lymphoma, those patients should have the first shot at getting the drug. The second priority is the possible number of years of life remaining. For example, pediatric patients and young adults before older adults. Third priority is patients on a research protocol to attempt to maintain integrity of our research results. We are an academic medical center. And then the fourth priority would be patients currently undergoing treatment with demonstrated response to therapy. And while we were developing these guidelines, we did have ethics sit in on our meetings also, as well as legal from the institution and others. We also thought it was best to have a transparent system if we ever did have to get to the point of allocating drug. So the consensus and committee approval came from, we took it to the faculty meeting. Of course, we took it to legal. We actually took it after ethics consulted for us. We took it to the ethics committee of the institution. And finally, we took it to Pharmacy and Therapeutics Committee, and from there up to the medical board to get approval for this drug shortage allocation plan. So just some points, I guess, about chemotherapy drug shortages and med safety, kind of bringing it back a little bit to medication safety. It's a challenge to maintain electronic records in an era of multiple changing chemotherapy shortages. For example, with dacarbazine, we don't normally carry the 100 milligram vials, but that's what we can get right now on allocation. So we had to fix our electronic record for that drug so that we could use the new vial. Also, new manufacturers are problematic. And there is a possibility of errors with the incorrect medication record. For example, Johnson Creek last week couldn't get leucovorin in the concentration we normally get it in. So I had to order it in a different concentration, which makes it more difficult to figure out the right amount to put in. It can also have different dilution or administration instructions. So if all of this is going on behind the scenes, we ask the providers to help us with maybe rounding doses so that we're not wasting drug, with prioritizing patients. But behind the scenes, we're running around trying to find the drug, find any sources of the drug, and also getting our electronic medical record updated with this information. And I guess I'll stop there.